Khalid, we have got 2-3 questions in the chat box. Let me take the first one and then you can ask the second one. The first question is for Yusuf Al-Saleh, and it is, if we need to reduce sulfonylurea dose in suhoor, by which percent we shall reduce the dose? Yusuf Saleh.
Thank you for the question. I think it depends on the magnitude of control of the patient. So excellent A1Cs, higher risk of hypoglycemia if you continue the same dose. Maybe 50% is advisable at that stage. You know, glycoside MR, which we commonly use, at least in Saudi Arabia, it comes in 30, 60, and 120, 30 or 60 tablets. So most of the time you need to break the tablet, the 60 milligram, or take 30 milligram. So well-controlled patient on 60, maybe you need to go to 30 milligram. In our practice, those who are poorly controlled, we continue the same dose. For example, if they are on 120 or 90, we just carry on with the same dose. We do not reduce the dose, and we haven't observed any significant hypoglycemia doing that. So it depends on individual patient who's sitting in front of you in the clinic, his control, his compliance with self-monitoring of blood glucose. There is always a window to check the sugar while fasting and look at the pattern. If there are tendency to lower sugars, then probably reducing the dose more is what you need to do. Those who are taking the old generation like glipizide, glibenclamide, the same thing applies. Probably sahur dose needs to be reduced, and those who are well controlled. A poorly controlled patient, probably they need to go to that, or even having another agent, which is not advisable during Ramadan. But all depends, what you need to do is depends on the individual patient, and what's the glucose monitoring is done, is reading during fasting hours, whether with glucose testing using finger sticks or flash monitoring.
Okay, thank you. Khalid, you want to take the next question?
Well, he's got a comment maybe. He said, thank you for all the excellent presentation. My question about variation of amount of glucose excreted in the urine by SGLT2 inhibitors makes superiority for those group with more glucose excretion. Thank you. This is for Dr. Al-Amin.
Thank you very much, Dr. Khalid. I found it difficult to understand the question perfectly, but I'll try to cover it. Probably the question was about how much the glucose excretion contribution in normoglycemia using SGLT2 inhibitors. Actually, the amount of the glucose excretion based on the threshold of the serum blood glucose. So the beauty of these SGLT2 inhibitors is a glucose-dependent threshold of activity. So if the patient is having normal blood glucose level, there will be no extra excretion of glucose. So this is the mechanism how the very minimal hypoglycemia incidences in using SGLT2 inhibitors. So the higher the serum blood glucose, the higher the activity of SGLT2 inhibitors, the higher the excretion of glucose. So it's a glucose-dependent activity, and this will, in a way or another, protect from having hypoglycemia. And if the question includes how fast the excretion of glucose will take place, the answer is very as short as few hours after taking the oral SGLT2 inhibitors. The fastest oral hypoglycemic agents to action is the SGLT2 inhibitors, where we expect the action to take place within 2 to 3 hours. And that's through the renal excretion of excess serum glucose. I hope I answered the question.
Yeah, carry on, Al-Amin. The next question is again for SGLT2, that which combination of SGLT2 has to be avoided?
Okay, thank you, Professor Abdelbasit. That's a very important question. Actually, we have now diversity of clinical trials. Most of the SGLT2 group was on top of metformin, pioglitazone, and DPP-4 inhibitors. Most of the studies in comparison to sulfonylurea and or insulin. So SGLT2 on top of metformin, DPP-4 inhibitor, and pioglitazone showed high margin of safety. When we introduce sulfonylurea or insulin, then the risk of hypoglycemia increases. So if anything to adjust is either the sulfonylurea or, more importantly, the insulin, and definitely more importantly, the MDIs.
Khalid, you can find the next question.
Yeah, the next question is from Dr. Sami Kintz. Again to Dr. Al-Amin. He's asking, how did you measure or assess the risk of hypovolemia with SGLT2 inhibitors during Ramadan?
Okay, that's again an important question. Actually, it was different. It was variable from different studies. Some studies we've included only the feeling of thirst, feeling of postural dizziness, or measurement of postural hypotension. So measuring the blood pressure sitting position and 5 to 10 minutes after the patient standing. And indirectly, it was hinted to by the difference in eGFR and creatinine level before and after Ramadan. But the more important ones are the feeling of thirst, feeling of giddiness, postural giddiness, and postural hypotension. Those were the markers of hypovolemia during our studies.
And the next question again to Al-Amin is that, can you comment on the concomitant use of diuretics and SGLT2 during fasting?
Okay, an important and tricky question. I think a patient who is on SGLT2 inhibitor and he must be on diuretics, this raises a question that whether he should fast or not. So I suppose this patient is having some sort of heart failure, and this will take him a step forward to high grade or high class risk stratification. But if the patient insisted, then if the patient is on high dose of furosemide, or specifically furosemide, and it's possible the heart failure status may allow some reduction in diuretics use, then we can reduce it by 25 or 50%. And this is not only during Ramadan. This is in all patients on diuretics, and we want to initiate SGLT2 inhibitors. So if it's safe, then we need to reduce the diuretics 25 to 50%. If it's approved by the cardiologist or the treating physician. But more importantly, we need to risk stratify this patient whether to fast or not.
Khalid,
Okay.
You can take the next question.
Next question is to Dr. Farougi Hamid. He says, thank you, doctor, for the excellent presentation. My question, if patient take to switch from GLP-1 to oral, from injectable, any special instruction? If somebody is shifting from an injectable GLP-1 to an oral one?
So if somebody is, thank you, Dr. Khalid and Dr. Abdul Basit, for your kind invitation. And so to answer that question, basically, if somebody is already doing well on an injectable, I would probably not change it, given that the response is good. However, if for certain reason you do need to change it, then in terms of the oral agent, the recommendation probably would be not to do it for just before Ramadan again, because we don't know how they will respond to from changing from the injectable to the oral. But if you have enough time, then by all means you can go ahead and do that. But again, titrate it slowly upwards, as I had shown during the presentation. Let's start with the first month of the lowest dose, which is 3 milligrams, then switch to the 7, and if needed be to the 14, provided you have enough time before Ramadan to do that.
Right.
Maybe that's bring us, Dr. Farougi, maybe this brings us to another question. Those, people may be taking different doses of GLP-1s. So maybe somebody will take in 2.4 milligram or 3 milligram or so on. Any data on the effect of different doses of GLP-1s?
In terms
during
of
Ramadan, if somebody is increasing the dose during Ramadan?
It's too early. I don't think we have enough data for the use of semaglutide in the different doses in Ramadan right now.
Thank you.
Yeah, agreed. I think I'll take the liberty of now calling it a day with answering a question myself about when to start SGLT2 pre-Ramadan, and the answer is obviously all the speakers have have very elucidately, clearly mentioned that please do not try no new drug before a day before Ramadan or something. It has to be a good comprehensive 2-3 months or at least 6 weeks plus follow-up time before we add on either SGLT2 or GLP-1s or sulfonylurea for that matter. I would like to once again thank Muhammad Hasnain and other organizers for this very successful event. I know we are running a bit late, and I don't know what time is it in those parts of the world where you are, but Hasnan has kindly chosen for me the time to be 11:30 in the night time when we educate every single patient and our colleagues to go to bed 9:30 to 10. So I'm once again very grateful gently to Hasnan for this wonderful arrangement of the conference, to the speakers for very, very comprehensive talks. And I like Khalid to say a few words before concluding. Many thanks and good evening or late good night from my side. Thank you.
Well, I would like to thank everybody who is joining the conference.